Johnson. Okay, the recording's on now. So I'm Professor Sonia Johnson. I'm from the Division of Psychiatry and I'm a Professor of Social and Community Psychiatry, and I'm happy to be chairing this seminar, which is going to focus on service delivery for children and young people against a background where there's quite a significant crisis in service provision. And our two speakers are two excellent early career researchers who I'll introduce just before they speak. What we'll do is have them back to back giving their talks and then invite questions once they've both given their talks. However, you're very welcome to post your questions in the chat when you think of them, and we'll then come to them at the end of the talks. Okay, so first, it's a pleasure to introduce Dr. Becky Appleton. She's a Senior Research Fellow at the NIHR Policy Research Unit for Mental Health, which has its lead base in the Division of Psychiatry. She's also the joint lead for the Evaluation and Policy module in the Mental Health Services Research MSc in the Division of Psychiatry. And she's a mixed methods researcher and systematic reviewer whose background is in youth mental health research. And her research interests in this area includes early interventions in mental health, digital mental health care, children's and young people's mental health and their help seeking, and service improvement in this area. So over to Becky.
Thanks, Sonia. I'll just share my screen. Okay, hopefully everyone can see that okay. Great. So, hi and welcome to this presentation. So, I'll be talking a little bit about early intervention in youth mental health, both existing evidence from previous studies and also some work which we're just starting in the Mental Health Policy Research Unit at the moment, which really aims to improve early intervention mental health support for young people. So just to start off with a bit of background, and why the need for early intervention is so crucial for this population. So it's been widely cited that young people are at increased risk of developing mental health problems, and that 75% of all mental health problems begin before the age of 25. This means that mental illness disproportionately affects young people, and mental illness actually represents the leading cause of disability in young people worldwide. So if you look at this graph, just focus on the light green part of the bars, and you can see that for these age groups, so kind of teenagers and young adults, that the light green section representing mental and behavioural disorders represents the largest number of years lost to disability for this age group. Recent statistics indicate that just under 25% of young people aged 17 to 25 have a probable mental disorder in England. And this represents kind of increasing levels of mental illness up to the COVID pandemic. However, despite this, young adults are the age group least likely to access mental health services. And we know that the majority of young people don't actually access mental health care when needed. There's some other information here which I guess shows the importance of early intervention in youth. We know that having a diagnosed mental illness during youth, so teenagers and young adults, can lead to an increased risk of substance abuse, poor educational achievements, things like violence, abuse, and poor sexual health in the future. Young people with mental illness are more likely not to be in employment, education, or training. And I think this is one of the things which really emphasises the need for early intervention during youth. It's often a time when young people are kind of putting down these life foundations, going to college, university, or moving into employment. And one study which I conducted a few years ago found that young people who weren't able to access mental health care actually reported dropping out of education or work because they were unable to continue due to their poor mental health. This group, who are classed as being NEET, young adults, are at risk of being socially excluded in the long term and also being economically disadvantaged over the course of their lifetime. Also, interestingly, we know that this group, so young people who aren't in any employment, education, or training, actually have poorer psychological treatment outcomes than other young adults. So this study was done comparing data from an IAPT service. So this again also shows the importance of timely mental health support for this population. And here is just a table showing some of the economic costs as well associated with poor mental health during youth. And one thing I think that is really striking from this is that it shows the additional cost of poor mental health of young people, and that these fall not only to the individual, but also to the health service and wider society. So things like social services, the education system, and youth justice system as well. There are also care costs, so informal caregiving, and as well as productivity costs, both for those informal caregivers and for the young people themselves. So I think this really shows that there is a strong economic argument for improved early intervention for young people. However, there are several barriers to young people accessing mental health services. I mentioned at the beginning of the talk that young people are the age group least likely to access mental health services. And there are several reasons behind this. One is just a lack of available services for young people, though this can differ across different areas of the country. And one reason for this is the transition boundary between child and adolescent mental health services, known as CAMS, or adult mental health services, known as AMS. And this disconnect between services can mean that young people experience discontinuity in their care. And one well-known quote in this area is that this break in services occurs at the time where it should be strongest. Young adults have also reported long waiting lists to access treatment, which they can find quite difficult. And we also know that some young people actually have relatively low levels of engagement when they do access a mental health service. And of course, all of these barriers are kind of faced more by young people from minoritized ethnic groups who can experience additional barriers to accessing community-based mental health services, and whom we know are more likely to access mental health services at crisis or inpatient level. Stigma is also another really big barrier to accessing mental health services for young people. One of my MSc students last year did a review in this area and found that young people can feel as though stigma is still very much a thing, both amongst the general public, but also their peer friendship groups. And as well, young people from ethnic minority groups also reported that they felt stigma from their family or their community. And this could be due to the family stigma was often associated with a mistrust of the healthcare system due to experienced racism in this setting. And I'll talk a bit more about some of these barriers in more detail. So I did my PhD looking at young people who fall through the gap between child and adult mental health services. And I defined falling through the gap as young people who were still showing a mental health need, but they weren't able to access any form of mental health support after reaching the upper age limit of their CAMS service, which is generally around the age of 16 to 18, depending on where you live. I started off with this systematic review, which found that only around a quarter of young people do transition to adult mental health services after reaching the transition boundary of CAMS. And it's interesting, this doesn't really mean that, everybody needs to go to an adult mental health service. Traditionally, adult mental health services are more for severe and enduring mental illness. But we do know that there was a proportion of young people who did show several different service transitions during a relatively short period of time after leaving CAMS, which implies that they were trying to find care that was suitable for them. I then conducted a narrative interview study with young people who had fallen through the gap. And I think the quote in the title sums up the difficulties experienced by the young people in my sample quite well. I'm just a long history of people rejecting referrals. And here are a few other quotes which I'll just leave up for you to read. But I think if you look at the first one in particular, this really emphasises that young people really value a choice in the type of mental health support that they can receive. So they kind of said, you know, however much you tell me to sign up to something on the internet or talk anonymously to somebody, which I think was in reference to a kind of helpline, that wasn't appropriate for them, that there wasn't any kind of alternative mental health support they could access. The other two quotes are actually from parents. And if you can see from the middle quote here, we say that at the end of care, they were told they'd go on to adult mental health services, but that they'd have to go back to their doctor, so their GP. And their GP wasn't really able to offer them any form of support or knew where to refer them. So again, that just shows the importance of more joined up mental health care for young people. And the final quote is from another parent, and I think this may relate to, you know, there's sometimes low levels of engagement that we find in amongst young people in mental health services. And this is because she had such a bad experience, she didn't want to see anybody. And that's referring to previous bad experiences of care in CAMHS. This leads me on to talking about early support hubs, which are a model of support for young people, which have been designed in order to bridge the gap between current mental health care and increase the offering for early intervention. So these hubs are mental health and wellbeing centres that are meant to provide open access, flexible mental health support for young people. The age range that they offer support to does vary. Generally, this seems to be between the ages of 11 to 25. So it does encompass that transition period where young people can experience discontinuity of care. They're often community-based services, which makes it as easy as possible for young people to access them, and they offer a drop-in service, as well as other types of interventions, so things like longer-term talking therapy or family therapy, for example. They will also offer support for social interventions, for example, signposting to things like housing or social services. And whilst each hub does tend to vary across the country, the majority do follow this youth information access and counselling services model, which you can see here. And this was taken from the Youth Access website, who are one mental health charity who've been really pushing for the rollout of these early support hubs. You can see from the different features of this model that it's really a case of there's no wrong door, there's one service, and young people can access lots of different types of support depending on what they need. So there's a range of different access points, from self-referral to online and phone referral as well, really to improve that access. And also it's meant to be a service that is very youth-friendly and stigma-free. And this is something as well which has been mentioned in evaluations of other types of mental health services, and that young people sometimes find going to adult mental health services quite intimidating. So there's this model instead, which is aimed to kind of tailor support to young people. Whilst again they do offer support for a variety of different mental health problems, it mainly focus on things like anxiety or depression, other types of common mental health problems, in addition to other wellbeing needs. Whilst there actually isn't that much published evidence so far on this model in the UK, there is some international evidence on similar types of youth mental health services. And Headspace services in Australia are a model of integrated youth mental health care, which has probably received the most research interest to date. And Headspace services provide holistic support for young people aged between 12 and 25. And they, as part of this, as well as mental health support, they also will offer support for physical and sexual health and provide support on drugs and alcohol, as well as providing support on issues such as employment and education. Some evaluations of this service have found that around a third of young people who access the service show significant improvements in psychological distress or psychosocial functioning, and that just over 2/3 of service users show significant improvements in either psychological distress, psychosocial functioning, or self-reported quality of life. So for the majority of young people, this does seem to be a really effective service in supporting their mental health. Jigsaw is a newer service based in Ireland, which aims to establish youth-friendly, community-based mental health care, which is free on the point of access. And as well as providing support to young people, it also provides a consultation service for adults, parents, and teachers if they would like some advice on how to support a young person who is struggling with their mental health or well-being. And again, initial evaluations of this service has shown that the majority report significant reductions in distress and improvements in well-being upon accessing the service. And I just included this paper here, which I think has a really nice overview of youth mental health reform initiatives which are occurring in different parts of the world. I'm now going to move on to talk to you a little bit about the project that we're currently working on in the Mental Health Policy Research Unit. And here's a bit of the policy context behind it. So charities such as Youth Access, the Centre for Mental Health and the Children's Society, amongst others, have been campaigning for the widespread rollout of these early support hubs, known as the Fund the Hubs campaign. So you might have seen this on social media over the last year or so. In response, the Department of Health and Social Care has made £5 million available to fund additional services at 10 existing hubs across England. This tender process has closed and we're awaiting on the announcement of who these 10 hubs will be, with the idea that these hubs will be split evenly across the south and the north of the country. The hubs will start their new service offering in April and will be funded for 12 months. And the Department of Health and Social Care commissioned the team at the Mental Health Policy Research Unit to evaluate this hub model with potential for a future wide-scale rollout. Here is an overview of our proposed work plan. Some of this is in the relatively early stages, so I won't talk you through all of this in detail, but here's an overview of the work we're doing to inform the evaluation and ultimately a logic model in how these hubs can support young people. So we'll be starting off with some evidence synthesis in the form of a systematic review to inform innovations in early intervention in mental health care for young people. We'll also be doing a qualitative meta-synthesis of young people's experiences of accessing these hubs, and also an umbrella review of early intervention approaches more generally. We're also planning to conduct 3 qualitative studies with service managers, clinicians, and young people who have used the services in collaboration with some young people with lived experience. And the ethics application is going in today for these, and with the view to starting data collection after Easter. And the main piece of work is a quantitative evaluation, so looking at the effectiveness of these hubs. And we've started this work with a consultation on outcome measures. So I'll be talking you through the systematic review and this consultation mainly for the rest of this talk, as these are the areas in which we've made the most progress. So starting off with the systematic review, we're aiming to find out what services or approaches to delivering early intervention mental health care are effective in terms of improving access to mental health support and reducing waiting times, improving mental health symptoms, and also improving social outcomes, functioning, well-being, and quality of life for young people with anxiety, depression, and other common mental health difficulties. We'll also have some secondary research questions which will look at cost effectiveness, summarising the methods used by these services and also the acceptability of any approaches. Moving on to the consultations, these were held before Christmas, and we had one with young people and one with other stakeholders. The young persons webinar was held first, and we recruited 26 young people with lived experience of mental health problems, mostly recruited from McPin. And the aim of this webinar was to find out what outcomes are important to them when they attend a mental health service, and also to get their thoughts on the demographic data that they would feel comfortable answering questions about, and the practicalities of data collection. We then held a webinar with stakeholders, which included service managers, clinicians, and academics who do relevant research in this area. And this really aimed to operationalise the findings from the young person's webinar. So, for example, thinking about certain outcome measures which related to the outcomes which were identified as important by the young people, and also exploring possibilities of comparison with other data sets or data linkage in order to really add to our evaluation. Here is just one of the polls that we did with young people. And this is quite interesting. So you can see that they've actually ranked well-being outcomes as most important to them, with mental health difficulties being down in 4th. So you can see that well-being is generally the most important outcome for young people. followed by the ability to do things at work, education, or take part in hobbies. So I suppose things like functioning, social functioning. And in third place was the progress towards goals that are set at the start of an intervention. We also asked young people some questions about the practicalities of data collection. And this generally showed us that young people wanted questionnaires to be as short as possible, and formatted in a way that didn't feel like they were completing lots and lots of different questionnaires. We also asked them when they thought they would like to complete data and when would completing data become too burdensome. So this is basically whether sessional outcome measures would be too much. You can see we've had some varied responses here. So we will take this back to our group of young people with lived experience, I think, for kind of further discussion. And I think the consensus as well was that young people would prefer to complete questionnaires online, and this would mainly offer more privacy and be easiest to do at the hub once they've had some kind of session with their clinician. And these are the outcomes that we're thinking of focusing on at the moment. So this is both in response to the outcomes which we said that they were important from the young people who took part in our webinar, but also then thinking about comparison with other data sets. So for the wellbeing measure, we've got the Warwick Edinburgh Mental Health and Wellbeing Scale, which is a relatively short measure of wellbeing and also has quite positively worded questions which young people seem to prefer. We do have the PHQ and the GAD-7 as measures of anxiety and depression, and these are in here so that we could compare the over 18s in our sample with other data sets, such as the IAP dataset, which uses both of these outcome measures already. The goal-based outcomes is another questionnaire which is often used in children and young people's mental health research, and goals was rated as young people as one thing that they thought was quite important. And this allows for some flexibility in the outcomes that are measured, as they can be more tailored to the individual goals of the young people. The goal-based outcomes is also used by another evaluation team based at the University of Cambridge, who are evaluating mental health support teams in schools. So this would allow us to have a comparison data set for young people who are under 18. In addition, we're thinking of including a very brief 3-item loneliness measure and a measure of objective social outcomes, either through a 4-item outcome scale or just by recording that things like referrals have been made, for example, as the Department of Health are really keen for us to include some kind of social outcomes in our evaluation. There are a few challenges that we're still trying to iron out at the moment. Things like how to take consent and data security. After speaking with people from NHS England, we're thinking that an opt-out consent would give us the sufficient quality of data that we need to do this evaluation. However, we do need to make sure that that is handled in a careful way so that people understand what their data will be used for. And also how to actually collect data in the hubs. So what online platforms do these hubs use already? And whether we could use the same online platform across all of the 10 hubs who are chosen to take part. If they do all use different platforms, then we'll have an additional challenge of how to merge the data sets from the different hubs into a coherent data set for analysis. We're also really interested in data linkage, both to other mental health data sets and potentially also to population level data as well, to look at who is actually using these hubs and further demographic information. However, this means that we would need to collect identifiable data, and we've had some challenges around how to do this at the moment. So this may not be ready for the beginning of our evaluation, but could be something that we could explore further, especially if these hubs are going to be rolled out on a national scale. Just a few slides of references. Hopefully these slides will be shared so you can have a look if you're interested. And thank you very much for listening. I look forward to answering your questions later on.
Thank you very much, Becky. That's a well-timed and very clear talk. So our second speaker, also from the NIHR Mental Health Policy Research Unit, is Dr. Jessica Griffiths, currently a research associate with the Policy Research Unit in the King's part of it, but Jess does have a long history with UCL, having done her Deakin Psych here and also the Masters in Clinical Mental Health Sciences. So she's got experience of working clinically as a clinical psychologist in various service contexts, including acute inpatient wards. And she's now working with us in a research role at the Policy Research Unit, where she's providing evidence on various topics to inform national policy making. And her particular interests are in crisis and inpatient mental health care. I just actually, this is a bit unscheduled, but I just wanted to share my screen because there's an extremely timely headline in The Guardian this morning, which really provides the background for Jess's talk, which is that there's been, against the background of long waiting lists, new publications from NHS data of huge pressure on children's emergency mental health services. So the issue that she's going to talk about what alternatives there could possibly be to standard wards for children and young people is a very timely one at the moment. So over to you, Jess. Thanks.
Thanks, Sonia. So I will share my screen. And I'll just get the slideshow going. All right, hopefully that's showing up for everyone. Like Sonia said, I'm Jess. I work at the Mental Health Policy Research Unit. And so I'm going to be talking today about a project that I co-led on, which was all about developing typologies of alternative approaches to standard inpatient mental health care. And I've listed on this page as well everyone else who is part of the working group for the project, which included other researchers at the unit, external experts, and lived experience researchers. And just before I kick off, just wanted to say, so this project was funded by the National Institute of Health and Care Research, and the views don't necessarily reflect NIHR or the Department of Health and Social Care. So, thinking about this project, so this was specifically requested by policymakers from NHS England and the Department of Health and Social Care. And we really aimed to map out existing alternatives to standard inpatient care, both nationally in the UK and internationally, and across all age groups. So it's quite a broad project. And so first of all, we had to start by thinking, okay, well, what are we considering an alternative to inpatient care? So we based it on a definition used in a previous study that Sonia was involved in, and we defined alternatives as models which aim to serve people who would otherwise be admitted to an acute psychiatric ward or receive long-term inpatient psychiatric care, for example, in a forensic ward or a rehabilitation ward. And they had to meet at least one of the following criteria. So they had to be based either outside of a hospital setting, be dedicated to a specific socio-demographic or diagnostic group, have a fixed maximum length of stay, involve changes in the practice of at least 2 different types of professionals in the service, or involve different types of professionals in care, or have a significantly different approach to managing risk. And there were some exclusion criteria as well. So in this project, we weren't focusing on perinatal services, addiction services, services specifically for autistic people or people with intellectual disabilities, or neurorehabilitation services, because there were other streams of work at NHS England focusing on them. So how did we go about identifying alternatives? So we had 2 main approaches. One was literature searching. So we conducted searches of academic databases, grey literature, But we also had an expert consultation stream where we reached out to over 120 different experts. So this included other academics, clinicians, managers, experts by experience. And we also circulated a call for evidence to over 20 different networks to try and get a really broad reach. And we had, I think, coming up to 80 responses to this call for information. And what did we do with these responses? Well, we developed 3 different maps of alternatives to standard inpatient care. We also have written up a paper, which we're hoping to publish, and also had an accompanying Excel database, which had more information about each of the alternatives that we identified. And I guess when we're thinking of the maps, so the 3 maps were alternatives for adult acute inpatient care, one for alternatives to adult long-term inpatient care, and then a map for alternatives for children and young people, which is what I'm going to be focusing on demonstrating and talking about today. But before I give you a look at the map, I just thought I'd share this key. So when we're looking at the map, any green text indicates models that are mainly focused on assessment and signposting. A grey border indicates models that we picked up from grey literature only. A world symbol indicates that the model is internationally based, not in the UK. And the scale symbol indicates models that serve forensic populations. So I will just switch tabs to show you the map, the typology that we developed of these alternatives. Okay, so I'm going to start just by zooming out really far so you can see like the whole thing in its totality. You can see it's quite big. We managed to capture lots of different alternatives here. But as I zoom in, you can see that they're organized into 3 main different branches. So we've got community-based services, hospital-based alternatives, and cross-setting approaches. And I'll talk you through each one in turn. So taking a look at our first branch of community-based services, here we picked up some various residential options which involve overnight stays. So we included things like crisis houses, which are sort of homely settings where people can stay overnight at times of crisis and receive support. There were much fewer examples of crisis houses for children and young people than for adults that we identified. We also picked up some intensive residential services. So this includes things like residential rehabilitation, where people receive sort of round-the-clock, 24/7 intensive support. Some of these services might be specialised for people with certain needs, for example, young people with eating disorders. And there were also some supported housing options, for example, full service partnership, where people receive their own tenancy, so they have their own place to stay, and they receive intensive external support from teams in the community to help them maintain that placement. Secure accommodation. So this is more catered towards forensic populations. So here we've got secure children's homes, which accept children and young people involved in the criminal justice system, but who can also sometimes accept welfare placements where local authorities can't find another placement that would meet their needs. And they, again, provide sort of round-the-clock residential care, on-site education and support. And there are also secure training centres for children and young people who've been convicted or who are awaiting trial. And those tend to be run by private companies and have a bit more of a punitive ethos compared to secure children's homes. Family placement schemes. So these are models where a young person might be placed with a host family or carer for a period of time. For example, therapeutic foster care involves structured therapy in a foster family setting, usually lasting between 6 and 9 months, and the aim is to support that young person to return to their family afterwards. Shared lives, on the other hand, the young person might be placed with a carer. These placements can be long-term, short-term, day support to provide respite, just depending on their individual needs. And as we scroll down, we can see acute day units. So these are a bit of an intermediate between outpatient care and inpatient care. So they're places where people go for day programs, they visit during the day, they can't stay overnight. The intensity of the programs can vary a little bit, but it tends to involve things like individual and group therapy, medication management, activities, educational support. And again, some of these might be specialized for people with specific needs, like people with eating disorders. And I guess the idea is that they're aiming to avoid the need for people to be hospitalized or to help people transition out of hospital back into the community earlier. This next branch of home-based crisis services, so these provide intensive at-home support to young people and their families during times of crisis. So here we've got crisis resolution and home treatment teams, as well as some other similar models. This next branch of emergency service linked models, so this includes police and ambulance street triage teams, where basically these include mental health professionals and police and/or paramedics, and these go out and respond to people in the community in crisis. Sometimes there are similar clinician-only units, and I guess the aim is to try and again avoid incarceration, avoid the need for hospitalization if possible. This next branch of drop-in crisis services, so these provide crisis support without the need for an appointment, and often that support will be out of hours as well. So it includes things like crisis assessment services and mental health crisis hubs, which started up during COVID, as well as crisis cafes, which are often voluntary sector-led, a bit more informal, and people are able to sort of connect and have that social support. And these drop-in crisis services, I guess they serve a little bit as an alternative to A&E, which we know can be distressing environments for young people in crisis. Discharge transition support models. So these really focus on trying to support that transition from inpatient care back out into the community. And so these models for children and young people include the supported discharge service and the hot bits model. And these, again, focus on things like providing psychiatric reviews, psychological interventions, physical health and practical support to aid that transition. Outpatient-based crisis services provide outpatient crisis support. So an example is the whole of service stepped care approach. The idea of this service is that young people presenting in crisis can receive sort of rapid access to brief psychological intervention, and then after that they can be linked in with longer term support if needed. This final branch here, community services with crisis function. So these aren't necessarily specifically for people in crisis. These are secondary care services which can also support people on their caseloads at times of crisis. So it includes things like enhanced case management models. You might have heard of assertive community treatment, which provides sorts of longer term care coordination support, as well as this model specifically for children and young people called crisis case management, which is much briefer and focuses on supporting families at time of crisis and can sometimes provide sort of respite as well. We've also got early intervention models here, such as early intervention in psychosis and FREED, which is an early intervention model for people with eating disorders, and adolescent forensic community services, which are tailored towards supporting young people who have complex mental health needs and a high risk of offending. And then as we scroll down to our hospital-based alternatives, so again, picked up a mixture of models here. Some of them are linked in with general hospital medical care, so things like enhanced psychiatric liaison services, where they work with young people presenting to medical hospitals or A&E with comorbid physical health and mental health needs. And so those provide a lot of sort of assessment, intervention, and connecting people in with support. There's also this model here where sometimes young people with an eating disorder, if they need to be admitted to a medical ward for medical stabilisation, they can have that brief admission, but with specialist input from a community eating disorder team. Brief stay crisis units. So these are places where young people can go for anywhere from a few hours to a few days, and they provide sort of assessment and stabilisation, really with the aim of avoiding the need for sort of a full inpatient admission. But as I said earlier, we were also interested in inpatient services that operated in a substantially different way to the standard. So here we've got some, including inpatient services that offer a specific therapeutic model. For example, safe wards is quite a widely known one. Inpatient wards for specific groups, for example, deaf young people, or children under the age of 13, or people with particular diagnoses such as early psychosis or eating disorders. And then we finally have short stay acute inpatient wards, which are different in that they have a fixed maximum length of stay, often sort of around the week mark, rather than allowing sort of longer term admissions as you would in standard models. And then we move on to our final branch, which is cross-setting approaches. So these approaches aren't so much based in a particular setting. They're more approaches to care that can be applied across different settings. So here we have things like open dialogue, which is an approach that really emphasizes involving people's social networks and families, having that sort of transparent communication. Got therapeutic communities, which are kind of structured environments. They're based on shared values like attachment and respect. And they really promote recovery through sort of social connection and activities. There are trauma-informed approaches, such as the sanctuary model. And a couple of these are specifically for children and young people, including wraparound with intensive services and multi-systemic therapy, which are really focused on engaging multiple systems around the young person. So whether that's family, wider social networks, school, health, the criminal justice system, to provide that sort of all-round intensive support. And then finally, we have a couple of whole system models, such as Trieste in Italy, which take a really community-based approach to mental health care, where they have no locked doors and really try to minimize restrictive approaches. And also the Buurtzorg model from the Netherlands, which kind of involves self-managed nursing teams that try and approach care in a really holistic, in-person centered way. So that's kind of a big run through of the map and the variety of things that we managed to pick up. I'll just return to my slides. So as you can see from that map, we picked up a really wide range of alternatives, including time-limited approaches, community-based approaches, ways of providing inpatient care that are different to the standard. And I guess that suggests that some innovations and improvements can be provided within existing structures. One thing we noticed was that although we didn't comprehensively geographically map the locations of these services, there did appear to be considerable geographical variation in what alternatives were available, both between different countries and also within the UK. And another thing we tried to look at was we tried to record the reasons why someone might be excluded from accessing each of these alternatives. Often this information was difficult to find or varied a lot between individual services, but where we were able to find it, some common reasons for exclusion were compulsory detention, people presenting with a high risk to themselves or others, and drug and alcohol use difficulties. And I think this is important because these are quite common comorbidities in people accessing inpatient care. And so it raises the question of really to what extent are these serving as true alternatives to inpatient care? And I guess some other potential gaps in provision we identified was a lot of the models I'd talked you through now tended to accept children in their adolescent years, particularly late adolescence. There seemed to be a lack of provision specifically for younger children, and also a lack of provision really around that transition between children's and adult services as well. So what are the implications of this? Well, I think that developing a typology like this really helps to understand and categorize the different types of alternatives to inpatient care that are out there, which in turn can help to inform service planning, delivery, and policy making. For example, it can help to highlight gaps in local provisions and also drive research and evaluation efforts for models which have received lesser funding and attention. So, for example, there are a few models which were tended to be voluntary sector-led, such as crisis houses and crisis cafes. And we often found that those kinds of models had a less extensive research base, potentially because these organisations may more often lack the funding to undertake rigorous evaluations. So I think there's a lot of potential directions that future research could take, whether it's more research evaluating the effectiveness of these different alternatives. And in doing so, I think it's important to take into account the priorities of all the key stakeholders, so patients, service users, carers, families, clinicians, commissioners, policymakers, to make sure that they're all addressed. But also to look at what works best for whom, what are the barriers and facilitators to implementing these services successfully, and also how can they be integrated together to form effective care pathways for people, because we can't just think about them in isolation, we need to look at that bigger picture as well. And then my final slide is just with my email, which for future reference. Yeah, I'd really welcome any further questions as well. Thank you.
Great. Thank you very much, Jess. Thank you. And I guess it's worth saying that a lot of these alternatives, although many of them seem promising, are only there in, as far as we can see, really quite a small number of areas, aren't they? Yeah. Okay, so there's a question about this from Niran. Niran, I wonder whether you might unmute and ask your question yourself. Hi, great. Do switch your cameras on, anyone, by the way, who'd like to be part of the discussion. That's great. Thank you.
Hi, no, just really clear and interesting, but both the presentations are really clear and really great work. I was just wondering for Jessica in the last one, whether there were any plans to make the map sort of publicly available in any form. Yeah, that was it basically. So, because it's very logically set out in those typologies, and I think that I just wondered whether there was any plans to make it available.
Yeah, so we've actually made it available as a preprint. I can share that link with you and maybe circulate it after the presentation as well. We're also hoping to publish a paper which those maps are included as part of. But yeah, good to have them accessible, I think, because you could spend quite a bit of time taking a detailed look.
I think that's the thing. I think the thing it makes me think of is that there's places out there that might attempt to do some kind of version of this with very little resource and very little time, and only find a fraction of the information that you've got. And from that perspective, it just seems kind of it would be a great resource for people, obviously with all the caveats around, you know, what we know about the quality or the, you know, to the extent to which these have been evaluated.
Yeah, definitely. I think in setting out to do this, there wasn't really anywhere else that had so broadly brought everything together. There's been kind of a bit more attention on summarizing sort of acute alternatives for adults, but I think this is the first piece to really look at all age ranges, take a really international focus and try to wrap it all in together. Yeah.
So NHS England were very keen to have this, weren't they? But we're not entirely sure what they're then going to do with it. But we hope something interesting. Yes. So there's a question in the chat from Elsa, who can't unmute because it's too noisy, saying that she wonders whether it's important to distinguish between mild to moderate and more severe mental health diagnoses when exploring this topic. Becky, do you want to give that a go?
Yeah, I can start off. I think the really interesting thing here is I suppose that distinction has already been made in how services have been established for young people. So I think, especially when thinking about early intervention approaches more generally, early intervention and psychosis services were kind of the first model to really take this early intervention focus forwards. And we also know that when young people leave child and adolescent mental health services, they are much more likely to transition to an adult mental health service if they have what's often referred to as more severe or enduring mental illnesses. So things like, again, psychosis or bipolar disorder, and in some settings, eating disorders too. So I think it is really interesting as whether that's actually the best way to do it or whether there is some flexibility. And I think in terms of the early support hubs, there definitely is that flexibility in that whilst it maybe is more designed for young people with kind of more common mental health problems, there is a kind of no wrong door policy. So any young person can go to that service and then the appropriate referrals will be made onwards. So that might be a kind of way of bridging the gap between having very diagnostic specific services, but also ensuring easy access as well. Jess, I don't know if there's anything as well that you wanted to add.
Yeah, it made me think we had so many conversations throughout the projects I was talking about where we were trying to, because I guess our focus was looking for alternatives to inpatient care. And so we were thinking, we're looking for services that can support people with sort of the higher levels of need. But a recurring question was just like, where do you draw the line? And actually that boundary can be really blurry and difficult to draw sometimes. And in thinking about provision for people, it was like, we often had discussions around, well, you know, there's services typically for people with lower levels of need or more preventative focus or primary care that actually form a really important part of that pathway still. So yeah, I think my reflection from our project was that it could be quite difficult trying to draw that binary between more severe, less severe. Maybe question how helpful is that sometimes?
Just one reflection though that did come out and that relates to some work that Susie Walker, who's my PhD student with the Policy Research Unit, has done, is that it does seem important to focus on the most severe needs, and particularly perhaps people who are detained under the Mental Health Act. Because I think for both adults and children, a lot of the alternatives that there are not actually available for people who are compulsorily admitted. So, and there aren't really models in either age group that have been clearly shown to reduce Mental Health Act admissions, which are, you know, they're inherently traumatic and coercive, so we should be especially concerned about them. So I suppose I would want to make a kind of particular case for a further focus on those. And have other people got questions or indeed any experiences to share or ideas to share about what might be the way forward? Do any of these alternatives or do any of these approaches sound particularly interesting, or are they relevant or not? Or what? One question is what ought to be researched, really? What are the kind of alternatives that we should focus on? Perhaps there are clinicians here. Essie, fabulous.
So I'm wondering whether there is also an additional question of, where would funding for these various alternatives come from, in a sense that, we may identify entirely reasonable needs and preferences, but are we going to be it's forever the dilemma that on one hand you want to highlight where there is need, but then are you actually increasing distress if there is then no means of addressing the need? And I'm not for a minute suggesting that we don't do this research, but I'm wondering whether there needs to be some thought, parallel also to thinking about, are there funds to deliver? Would kind of a first pass be to partner up maybe with something to run a pilot where you can really then actually things are identified, you can really provide it, you have something to show for with carefully sort of thought about outcomes that are measured, which could also show you change immediately, but also maybe some follow-up. I mean, just a few thoughts.
I mean, I suppose one important thing about costs is that services can save money even if they're quite intensive, if they do a good job of keeping people out of hospital, because hospitalization is colossally expensive. And for instance, early intervention services for psychosis work intensively with people in the community, but their care is actually cheaper than if people don't have them, because they're less likely to be admitted to hospital. So we didn't so much focus on the health economics, but that's actually a really important part of this.
I think just one point I can maybe add about the health economic argument for early intervention is that I tried to do some health economic analysis as part of my PhD, and it's actually really difficult to do a good health economic analysis with young people. I think in part because of the quality of data that's available at the moment, but also a lot of it is on things like future lost earnings, which are really hard to measure, or things like the impact of informal care. A lot of the young people who I included in my qualitative work as well found that their parents had taken time off work to go to appointments with them, or some parents had reduced their hours completely so that they could be at home more. So it's these type of costs, more informal costs, which are actually really hard to measure, in addition to cost to the health service.
Yeah, I think that, so the few points that come to mind. So first of all, I completely agree, and I've been involved in a project that has done health economics measures, so we've been constantly sort of ruining the fact that actually they're not really fit for purpose for particularly mental health. A lot of the areas where we might be measuring are so complex and not necessarily routinely measured, or not measured for everyone or well. So that's a tricky thing. But I guess the point I was trying to make is a little bit different, which is if we consult people and we take their views and they have some hope that there might be a change, but actually, I mean, it's not hard for me to believe that there is a strong economic savings argument there. But before you can accrue the savings, you have to have money to provide the services. And at the moment, if we consult people, do we give them hope that there is realistically ability to do that? And maybe there will be in some pockets. I don't think there will be whole scale, and there probably shouldn't be whole scale until there is an evidence base. But would the next step forward to think about how you either get money from the NHS or how you can partner up with someone else do a sort of a pilot look at, okay, well, if we can do this sort of more wraparound, more preventative model, how does it look like? Build a kind of a health economics evaluation, maybe a bit outside the box. And then you may have tools to sort of say, okay, well, this is totally reasonable to roll out. And you might have a next government who might be more sympathetic to it.
Well, to be fair, the hubs model that Becky was talking about, there is a funded pilot to evaluate it, and actually the alternative next government has said they would roll it out. So I think, you know, the pressure on services is such, there is actually a willingness to invest. In a way, a question is what in of all the options. There's an interesting, draw people's attention to an interesting post from Ramya, who's a child psychiatrist, in the chat about crisis teams for children and young people and their belated rollout and the promise that might offer. Any other thoughts or questions or about what might be the focus?
Sorry, my camera's not working.
No problem, go on.
I'm a PhD student at Warwick University, but part of my PhD is evaluating kind of a new approach in Birmingham, and the team are working to avoid kind of hospital admissions for young people with complex psychological needs. But it's interesting, the discussion, because basically they're a pilot, and kind of as time goes on, it might be that I'm not even able to do my evaluation before the funding runs out, which obviously is a big issue. And also the other thing that I found is just having all of these different ideas that kind of are existing in different spaces, is trying to plan an evaluation that is kind of robust enough to say this is a good idea to take forward when you're working with relatively small numbers of people. And there are so many interesting ideas, but yeah, not having that kind of standardized way of providing kind of a really good, like, this is what we should do, this is what we should take forward, is quite tricky. So the approach that I was planning to use was kind of a case study evaluation, to try and see kind of what's working for who in what context, because the young people that come through are so different as well, like children coming in from residential care homes, but also people in family homes. And yeah, it's just really different presentations. But yeah, it's been really good to have it mapped out, because yeah, it's kind of exactly what I was looking for as kind of a background to what we're doing.
Sounds extremely interesting to hear what you are able to do, yeah, in that context. But Niran, question.
Yeah, I don't have any answers, but I suppose, I guess maybe something we don't always do is we focus quite a lot on the micro, without maybe always kind of connecting up to what the macro implications of that might be. And I think the health economics kind of conversation is all, you know, is kind of a nice example of that. You know, everyone's quite comfortable with thinking about the cost saving to the NHS, but we don't, you know, I'd have thought there probably is data out there which does has in certain cohorts mapped out what some of the societal impacts are. It's probably kind of a creative way of bringing that together to, and it will only be model data, but kind of like model, we have good reason to believe that there would be good, you know, significant savings from a societal perspective if we're able to intervene early, for example, you know, and have an articulation around what some of that might be, which can then be tested. But then, and also when you're doing some of these evaluations, thinking about, I suppose there's one, within the context of the evaluation, thinking about who is the cohort that you're focusing on, what is you know, at a population level, you know, how significant is that cohort? Which of the cohorts may also be similar and also be addressed in a similar way? But then also, I think in terms of the pilot issue, and pilots only being funded for a short amount of time, is there something that we should also be communicating about realistically? What is sort of like, based on current data, what is the minimum that a pilot should need to run for in order to actually be able to demonstrate an effect, to give it a fair road, a fair runway to actually achieving something that we can evaluate? So I think it's complicated, but I suppose I think there's something about when we're designing our studies, maybe thinking a little bit about how we can realistically apply the evaluation findings that that are feasible to achieve within the broader population context.
Becky or Jess or even Una, who's another of our colleagues, is here. Any thoughts about that? About the issues people have been raising?
I mean, I think I just briefly, I mean, it's not in this same setting, but it really relates to the piece of work that we did last year in the Policy Research Unit about social interventions. And we did this big mapping exercise of the social interventions that were out there for people with more serious mental health problems. And we found it's the same kind of thing, lots and lots of small scale pilots, but it was kind of lacking one overarching model that had a lot of robust evidence behind it. So yeah, just say that I know that that is something which is probably important across lots of these types of mental health evaluations, is that there's lots of these small pilots that could look quite promising, but lacking then a kind of more robust evidence base. But I'm not sure I've really got anything about what the answers are to that.
An awful lot of research in mental health is on new services as well, that you don't, even if there are more substantial projects, there are often services that only just been set up. And then, of course, what happens is what may happen to these hubs, that there's a nationwide initiative all of a sudden, and there isn't really evidence, but it all gets implemented, and you then have to think what could be done to evaluate that kind of rollout. But yeah. Jess, any final thoughts from you?
Yeah, I guess it was just making me think about how in research, I think often it could be quite idealistic of like, it'd be like great if we could have randomized controlled trials, like directly comparing different services and projects. And I know that when we were looking at sort of the literature and evidence associated with the different alternatives we picked up, it's so hard, I think, sometimes with the resources that people have to capture the outcomes that are important to different people, because what commissioners are interested in and that'll help inform their decisions may well be quite different from service users and carers and families. And also, like, we identified very little about, you know, what are the factors influencing how effective these models are, and like are there particular subgroups that they work better for, in what context, how can they be implemented in a way that's helpful. So yeah, I think just a reflection from me that the idealistic view of it is very complicated. And yeah, I don't necessarily have an answer, but yeah, I agree with you that feels like there needs to be some middle ground of like providing enough to help inform decisions, while still balancing the flexibility of like focusing on each service and the nuance of that and what's important to capture in that context.
And a very good point in the chat, that maybe it's about improving our skills in synthesizing the evidence there is. And I guess that's right, isn't it? That randomized controlled trials can take 10 years by the time if you do them kind of perfectly and go through all the stages, but routine data is getting better and holds some possibilities. Okay, great. So I think we're coming to the end of our time. Patrizio Essi, did you want to say anything at all?
I think Patricia will tell about the events that we've got coming up. I think she's put them in the chat. So
That's right. So we have
an
an event tonight, 6 to 8 p.m. At the Institute of Child Health. You can also join online if you can't come in person. And then March 13th, 2 to 5 p.m. that it will be in person only. And it'll be at the Institute of Neuroscience. And both links are in the chat.
And the spaces are not indicative of content. They are just where we managed to get space at UCL. So,
tonight we'll be talking about what's going on with adolescent mental health. And in March about ethical issues in children and young people's mental health research.
So we hope you can join, and a huge thanks to both speakers who were just fantastic, such clear presentations. And thank you, Sonia, very much for chairing.
Thank you. Thanks everyone for coming as well. It's a really interesting discussion. Thank you.
Thanks for the great talks and discussion.
Bye.
Thanks.